Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Jessica. How are you doing today?
I'm doing great. Thanks, Dennis. How are you?
I'm doing well. So your tag on social media is the Combat Midwife. I have been to combat, and to be honest, I haven't seen lots of midwives running around. How did you get that? How did you get that name?
Yeah, great question. So I'm both a paramedic and a midwife, and I have been working in some capacity with military medicine for, I don't want to say the number out loud, Dennis. Makes me feel old. But I've been working with them in either AIT, so 68 Whiskeys. I worked with the flight medic program and then eventually moved on to special warfare. So I've had my hand in military medicine for some capacity for quite some time. And my students started calling me that. And I kind of like brushed them off and said, knock it off, guys. But it just stuck. And then my coworkers and brass was starting to call me that. So it's now turned into an awesome business where I travel all over the country and I teach really awesome workshops to help providers either in or outside of the military learn how to care for women and children in absolutely any situation. Shit hits the fan, grid down, or your own living room.
Wow, awesome. So just doing some quick Googling, as far as maternal deaths worldwide, the World Health Organization says the top two are postpartum hemorrhage and infection. So I gotta be honest, I'm pretty decent at trauma medicine. When bullets and steel hit meat, I generally have a good idea what to do. However, postpartum hemorrhage is not really something I've practiced at all. So if you wouldn't mind, why does that even happen?
Yeah, so that was a really great place to grab some data. I don't know how long you dug around on the WHO's website, but they have a really cool interactive graph where they actually show infant and maternal outcomes in all countries going back several decades. So I know everybody has their kind of own opinion about the WHO, and I do too, right? Like we have to kind of take some of their data with a grain of salt, but I will tell you that they have really amazing data regarding mommy and baby outcomes. And when they say postpartum, they're looking at the whole first year after baby's born. And I think that's really great data because sometimes we get, even in trauma medicine, sometimes we get some data and we're like, well, did you follow them outside of the hospital? Like, did they leave? I mean, I'm glad you got a heartbeat back, but did they go home? And so that's some really great places to grab some data. And I use their numbers all the time. Amnesty International is another really great place to get maternal and infant mortality rates worldwide. They kind of look at things from a different set of lenses, if you will. And whether we look at first world or developing nations, postpartum hemorrhage and infection really is a big problem. And it kind of comes back to what is the provider doing? Because if we're looking at the commonalities between first and developing nations, that's the one thing we really had in common. And that is kind of what you said, I'm really good at trauma. What you said, I feel comfortable with that. And when the stuff on the outside goes on the inside and vice versa, I can plug holes all day long. But not a lot of people feel super duper comfortable in OB-GYN. And so really just mismanagement of obstetrics is really where we start to run into a problem.
I guess, where is the mismanagement? I mean, people have been delivering babies, animals been delivering babies for thousands and thousands and thousands of years. They've kind of figured it out. How is it a provider comes in and now screws it up?
Because we want to manage something that is a natural, biological, physiological process. Not that breathing and giving birth are the same thing, but we don't micromanage people breathing. We only intervene when they're not breathing appropriately. So the same thing happens in obstetrics. So we'll just take it from that rudimentary example and kind of bump it up a notch. And that is, birth is a normal physiological process. And you are correct. We're still on the planet, which means people are still having babies, right? Like we're still on this ball. So the problem winds up happening when we start to micromanage normal physiological processes. And anytime we intervene in that process, we start to cause a problem, which then kind of taps into that Hegelian dialect problem, right? We created a problem. Now we have to create a solution. Now we've got more problems. Now we need more solutions. And we just have this domino effect of junk that we really, if we had just left it alone from the beginning, we wouldn't have had that problem.
So, I mean, is there any, I guess, part of the process that's particularly the cause? Like I remember.
Yeah. So when we talk about postpartum hemorrhage specifically, the powers that be kind of put it into 4 main categories. And I'm going to say there's 4 main categories, and one of those has a subcategory, but that's my opinion, not theirs. So there's tone, tissue, trauma, and thrombin. And those are the 4 main categories that kind of perpetuate that domino effect. So when you look at the World Health Organization, they say that over 90% of birth is uneventful. And then when you look at what they mean when they say that, so they have little asterisks underneath there, and they kind of explain what they mean by uneventful. They say that it doesn't need any intervention. Leave it alone. Don't touch it. So less than 10% of birth needs us to do something. And then out of that 10%, we might need to do something like a surgical procedure, such as a C-section. The United States has way over a 40% C-section rate. So there's no way in heck that you can even remotely tell me that we have 40% of our childbearing women are broken. Like that's not mathematically sound, right? So what happens is we've kind of intervened and started doing things to women. We've put them in sterile boxes. We've micromanaged placental delivery. We've put them on Pitocin for induction, which has a black box warning. And we all know, everybody in obstetric knows that we're just kind of throwing stuff at the wall to see what sticks, and we're trying to speed up something that should normally take 12, 14, 24 hours. But we live in a microwave community where we want everything to happen like that, and that's just not what birth is like. Birth takes hours and hours to happen. That's just normal. It's how it's supposed to be. Baby has to mold and fit in the birth canal, and their head has to get squished, and their lungs have to get squished to get all the gunk out. So when we start micromanaging those things and we add stuff to speed it up, well, the uterus couldn't go through its normal process. So now we've caused problems. So the number 1 on that list was tone. So we've added a bunch of medications to the body to say, hurry up, have a baby, hurry up, have a baby. If I tossed you outside and I gave you pick a sandbag at a weight that is just kind of your max, and I said, okay, so just keep picking it up, just keep deadlifting it. You can do that for a while because you've trained, but when there's no end in sight and I just keep making you do more and I keep adding to the sandbag, you're eventually going to pull something, tear something, hurt a ligament or tendon. You're going to pull a muscle. Something's going to break. And that's what we're doing to the uterus is we're pumping this mama full of meds going, hurry up, have a baby, hurry up, have a baby. And now we've got a uterus that doesn't know what it's supposed to do. it's a very, it's an organ, but there's a lot of muscle layers to that. And we've stretched out, we've squished it, we've told it to hurry up and contract, and it wasn't ever supposed to do that. So that number one problem is tone. We sped up something that wasn't supposed to do that. The next one is tissue. And so that's when we've got some sort of retained placental or amniotic sac component inside the uterus. Usually it's like caught on the cervix because the cervix is trying to close, and maybe something just stayed and hadn't kind of passed on its own, or you were trying to speed up the placental delivery, which is very common in the United States, super duper common. When I deliver a baby, I do not rush the delivery at all, but I definitely don't rush the delivery of the placenta. I let it come out on its own, and I never even clamp and cut the cord until at a minimum of an hour after the baby's born, usually much longer than that, because I want that baby to get all of his blood back into his body. So depending on what textbook you read, there's either a third or a fourth of the baby's blood volume is in the placenta at any given time. So kind of think of it like our spleen. And so it's a kind of an external spleen, and it's filtering out baby's blood. So if we speed that process up, it's having a hard time getting the blood back to the baby. And it's also waiting for the communication hormonally from baby to placenta that says, thanks, I got this breathing thing down. I don't need you anymore. So there's a reason I wait. I don't clamp and cut that cord until at least an hour after the placenta has delivered. But should, for some weird reason, something be going on and you're dealing with a complicated issue and you're trying to encourage, I would rather use the word encourage the placenta to come a little bit faster because maybe you're dealing with a problem, then proper delivery is really important. And so knowing how to actually remove the placenta will truly reduce your risk of having a hemorrhage, because we don't want to leave those cotyledons. So there's a smooth side of the placenta, and that's the fetal side. And then there's that bumpy kind of looks like a brain. That's the maternal side. And it has all those little nodules, and those are called cotyledons. And if that stays inside of mama, the body's going to go, hey, it's not supposed to be here anymore. Baby didn't pay rent. You got to go, right? Like we're done. So if you're dealing with something like that, repositioning mom is huge. Getting her to stand up. I usually have them stand up and then flail like she's going to go over a fence, right? Like she's going to jump over the picket fence, make those really big movements to kind of wiggle around her body. Squat is another good one. If you have access to a toilet, I usually put moms on a toilet because everybody knows how to relax their bum on a toilet. And I usually just have moms take both her hands, find the fundus, which is going to feel like a ping pong ball in the abdomen. And I usually just say, can you just massage this, push on it, and relax your bottom? And usually your heel plop, 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 plop in the toilet. And that's going to be some blood clots and a cotyledon, and you'll see a significant look of your patient too. She'll go from being that ghosty, pasty white, right, to actually color will start coming back, and that shock looking patient will go away. So that's tone tissue trauma. So this is where I said the kind of subcategory was, where it could be what they mean when they say trauma is like genitalia trauma, cervical laceration. But I would like to go a step further and say, is there actually an external type of trauma that maybe caused mama to go into labor in the first place? So that's just our EMS background, right? And so that's my little kind of subcategory. That's pretty self-explanatory. Is there an external laceration? Is there a cervical laceration? And then there's the last one, which is thrombin. And good grief, even if we were inside the hospital, there's probably going to be a poor outcome with that anyway, because now we're just dealing with a blood clotting issue, right? So unless you had a surgical team and a bunch of different blood options and a junk ton of medications, we might not have a great outcome with that one. But TXA would be at least helpful. It would be pointing us in the right direction, at least if we were outside of a facility.
Okay. I mean, that absolutely makes sense. And I would not even know if there was a thrombin problem because I don't have any labs to even know.
Nope. Yeah, exactly. If you're, and I wouldn't either, right? If I've worked in refugee camps, I've worked in disasters before, natural disasters, I wouldn't know either. And I've had women that are just bleeding and they're not responding to anything. I've gone through all my algorithms and I'm like, I don't know, ship her out. There's nothing else I've done all the things, right? And that could happen to any of our patients, right? We've probably seen people like that in the back of our ambulance before where we've done all this stuff and you're like, they should be responding, but they're not. So you kind of just have to go, I don't know, not your day, I guess.
Yeah, that makes sense. So I guess as far as not being the cause of this problem, I guess what kind of advice? Essentially just comfort the mother and let her do her thing?
Yeah, absolutely. Getting mom in really great positions. We're dealing with outside of the hospital situations. You're dealing with don't have access. I'm out in the boonies somewhere. I'm doing some sort of outside of probably sometimes even our scope, right? And so I guess depending on your scene, what is your scene like, right? Can you keep her in that environment? Is it safe to be where you're at? So obviously all of those fun things. But yeah, just let her walk around, squat, lean on the wall, do all the things. Women do not want to give birth laying flat on their back. I know every TV show and every movie and every darn EMS textbook tells us to put them on their back, but that's the absolute worst thing to do. It's highly uncomfortable. You've got a baby's weight and all that water, right? All that amniotic fluid is now sitting on top of her lungs. It's extremely uncomfortable. A lot of women feel like they're drowning because they've got all that weight sitting on them. So getting them up off their tush. Sometimes they're tired, and I do get that, and you will find them sitting. Or you may find them laying down, but they're laying on their side. That's fine. You can totally rest, and you should be resting in between contractions. But usually I'm like, get off your butt, right? If you've got active labor going on and it's progressing, off your tush, because you've got to get that body movement in order to let that baby spin. There's something called cardinal movements, which are the steps baby has to take to spin around inside there to come out. And what makes sense to me is when you're removing a cork from a wine bottle, everybody knows how to do that. You twist, then you pivot, you twist again, and you pivot. And while that's, again, a very kindergarten example, it's just an image that makes sense to me when I was learning all those steps in midwifery school of, we're compounding baby, right? We're squishing up into a tiny package, and we've got to get them through this tunnel, which is kind of like what a cork is doing in a wine bottle. And so if you can kind of keep that image, the only way to do that is kind of keep that wine bottle in a nice upright position, right? You need it in an upright spot. So getting mom off her tush is really important during labor. And then really managing the labor in a way where you're just not poking and prodding a ton. I really can't tell you the last time I did a vaginal exam, probably over a year ago. And I'm a midwife. I deliver a lot of babies. I just don't do them often because it increases the risk of infection. They're not super comfortable, and it tells me nothing. it's not like if she's 6 centimeters, I now know, well, there's a 3-hour countdown. You could have 10 different women at 6 centimeters. 3 of them are going to have a baby in the next 2 hours, and the rest of them are have a baby sometime in the next 24. Right? Like it doesn't tell me anything. It's not a gauge. I wish it was. I really do. I wish it was like the gauge in our car, and we know, oh, I got half a tank. I know I got 150 miles left. Right? It doesn't mean that. And so because it doesn't provide me any info, I very rarely do them.
So another thing you mentioned, like trying to hurry that placenta along after the baby's been born, right? Yeah. So guys, and I've seen it, I mean, it's a cord. People can't help but play with it. And so they put their finger around it, and they keep, like when I've seen it done, they're saying, just gentle, slow pressure, and it guiding it out, right? And we always put nice words to something that essentially is like pull slow. Don't.
That is true. I never thought of it that way, but you are correct.
Again, this is something that was meant to happen by nature, right? So essentially, just don't freaking touch it, or.
Yeah. So. Right. Now you made me rethink how I'm going to explain this, because we do add euphemisms, right, to these words on it kind of is confusing. So what I want you to look for is a couple of things, and that is mom went from not having went from having contractions to not having, because now we have a baby in our arms, right? And then she is going to say something like, oh, I feel a lot of pressure, or oh my gosh, my contractions came back. And you'll see her make the movement I just made, like, oh God, they're coming back. Because that was traumatic, right? That was a lot of work. And oh gosh, those sucked. She may also have something called a detachment bleed. So kind of like when a scab comes off of us and there's that serous fluid and bleeding that happens. Same thought process. So that's why it's really important to kind of have mom in a position where I can look at her and baby, so I can watch both my patients, but also kind of have an eye on the perineal tissue. So I just usually have her on a Chuck's pad and fold it over so she has some modesty, right? And then I just kind of peek every once in a while and go, Mom, I'm going to check your bleeding. Is that okay with you? And I usually put a hand on the fundus when I'm doing that. So I'm kind of peeking and going, okay, so the fundus is at or beneath the umbilicus, which is where you want her after birth. That if it's above that, check the position, and 2, is the bladder full? Because if her bladder's full, the uterus can't clamp down, and so the uterus is going to struggle and it's going to continue to bleed. So again, I usually say, Mom, can you stand up, wiggle your legs, move around, move your hips, and then let's sit back down and I'll check it again. Okay, it's still full, it's still too high. Okay, Mom, to the toilet, or a sits or an in and out cath or whatever is appropriate for your treatment plan. And then I'll check again. And if I have that it looks like a big gush, and then it goes back down to the normal trickle of postpartum bleeding. That'll tell me, oh, the placenta's done doing its job. Let's remove it. She may also say something like, I feel achy. Like I feel like I'm getting the flu. So it might be like achy joints. That's also a good indicator the placenta's done. We can remove it. So I loved your hand movement. Yes, you can curl it around your finger. That's perfect. That's how I was taught too. And then what I do instead of pulling or slowly removing is I usually just tell my moms to cough, because you cannot clamp down on your tuchus and cough at the same time. And I just remind the mom, no bones. There's no bones in this. It's just gloopy. It's going to come out really slow and easy. No, zero pain. There's no pain with this. You're going to feel a whole lot better too. And she goes, oh, okay, yeah. So it helps her kind of register with her brain. And again, if you're having kind of a hard time, I'd have her stand and sit back down. I've delivered a lot of moms in like a squatting position for the placenta, just like I did with the baby. And that can be very helpful too. Just put a Chuck's pad underneath, or a kidney basin or whatever you've got. That's helpful. But I just anchor it around my finger because it is slippery. It's hard to kind of keep it together. And then once there's a protruding part of the placenta coming out of the vaginal opening, I kind of leave it wrapped around my finger and then pinch that part together, almost, for a visual help, almost like a taco or like a pizza, like you'd pinch it together. And that just helps anchor it because, again, it's very slippery. And then I just spin it on top of itself. And the reason I'm doing that is because, remember, it's the placenta and the amniotic sac. And we don't want to lose a piece of that. And then it's inside of her and then she's bleeding. So if we slowly rotate it on itself, it's going to sweep the uterus, sweep the cervix and the vaginal vault. And then we cross our fingers and go, yep, see, now everything should be intact, because now you can bring it out, put it in on the Chuck's pad and look at everything and go, yeah, I don't have any missing parts. Whereas if you just bring it out, you might injure the placenta and the amniotic sac, so it's going to be harder to investigate, if that makes sense.
It sure does. Yeah, I've, with my own children, they lay it out, the placenta, and look at it like a jigsaw puzzle quick and see, do they have any missing pieces? And, thankfully in my case, there were none. But, and then I think you're mentioning earlier, if there were any missing pieces, that's when you're having the mother stand up and move around or sit on the toilet and oscillate, and then they'll fall out.
They usually do. I've delivered a lot of babies, and I really only had one mama that I've ever needed to glove up and actually go in and do a manual removal of what was left. We got lots of zeros behind. I've never had a big problem when you're properly managing postpartum. Yeah.
Nope. That sounds like nightmare fuel to me, but,
yeah. It's pretty cool when you do inspect the placenta. You can even insert a hand into the amniotic sac and hold it up. Like, you can raise it and see, oh, look, I'm not missing any pieces of the amniotic sac because it perfectly comes together. Like, you don't see any jagged edges. And that can be really helpful to identify, because you're like, okay, great. I can mark that off my list. There's no retained, products of conception left in mom. I can just check that off my box.
And then essentially after that, you mentioned like roughly an hour after birth, then you clamp the cord. Yeah. Are you looking for anything else in particular?
Yeah, I really want the cord and the placenta the cord will be completely white. You can actually almost see through it if you were to hold it up. It's very opaque. And then the placenta goes from being a very dark liver-looking organ to very fair pink, because all that blood has gone back into baby, which is exactly what we want. If I took a fourth of your blood volume away, once you felt better, you punched me in the nose, because that's not kind, right? So we don't want that to happen. And so we want all the blood to go back into baby. So what I do is, once I've inspected everything, I just, again, wrap it in a Chuck's pad, and then I stick it between baby's legs and mommy's tummies, because I want baby's chest on mommy's chest. I don't want that to be separated, but I don't want the cord to get pulled or, moved or anything. So I just tuck it between baby's legs and her lower abdomen. And then she can move baby around and nurse and look, and I can listen to lung sounds and heart and do all the things I need to. I can even scoop her up and move her if I had to, right? If you were in a really crummy situation and you had to go right then, you could still package her and go, because it's not gonna pull on baby.
Okay. So that's if everything goes well. Let's say things aren't going so well. And I would say probably the more likely scenario is somebody's bringing me a patient, female patient, she's bleeding out of her vagina. Like, I need to figure out what the hell just happened. Barring my basic March algorithm, T-Tri-C type stuff,
Sure.
what specific assessments would you be doing for mother-baby type assessment?
Yeah. So I want to know how long she was in labor. I want to know when this baby was born. I want to know what number baby this is. Those kind of basic things help paint me a picture of what this woman went through while I'm doing all the things to set up. And I mean, again, they've cold pit off of even all of the trucks from, civilian EMS. So I would just jump straight to TXA in your scenario, because that's just what you've got. And you don't have to learn anything new. The same dosing for a trauma patient is the exact same dosing for a postpartum hemorrhage patient. So you don't have to learn anything new. So yay. If you're really thinking it's bad and you're jumping to blood, again, follow your protocols. You don't have to do anything different because it's a postpartum patient. So again, easy. I do personally carry Shepherd's Purse and Angelica. I love those as my replacement for PIT. I very rarely use Pitocin, if ever. They just cause contractions that are not of this world. They are straight from the abyss of hell. They're horribly uncomfortable. And because of that, they can cause a tone issue. So they can cause the uterus to clamp down so hard that now we've caused that problem with, go back to the sandbag image I gave you, where I'm just saying, pick it up, pick it up, pick it up. And I keep adding weight to it. You can have that opposite effect with Pitocin. So I just really like to use my herbs for that. And then I would just, if mom's not responding to that in the same period of time, like with the dosing of Pitocin, you did it every 2 to 5 minutes of a redose. If mom isn't responding to that, I would just go straight to TXA. Like I don't what around with postpartum hemorrhage. I just don't.
Okay. So if you happen to have Pitocin, which we don't, or now you mentioned Shepherd's Purse and Angelica. Yes. Those I'm guessing are herbs in the US or at least Americas.
So those are the American names for those herbs. What are they called in Chinese medicine? I don't know. I'd have to look that up for you. I don't know the answer to that. Those words are hard to pronounce and I don't memorize them. I learned it in school and kind of brain dumped it. Sorry. But those are very readily available herbs. However, you need to know how to use them. You can't just grab them at your local health food store. They're not sold there anyway, but you can't just grab them and then be like, I'm just going to use them. You need to know what they're doing. So you're using them to simulate the contractions of the top part and the bottom part of the uterus. So you would never, ever use them if you thought anything was still inside mom. You would need to get the cotyledon, the placenta, the amniotic fragment, something, whatever is inside of her would need to come out. But I've used those herbs for miscarriage, right? Like I have a baby in a basin in front of me. Obviously it's intact. Mom is hemorrhaging from just giving birth with a miscarriage, because that's what a miscarriage, you are giving birth. And she's bleeding. I've used them for that when I know everything is out. So they're pretty versatile. And I've also used them. So postpartum can hemorrhage, not to scare everyone here, but it can happen up to 12 weeks postpartum. So you could, in theory, have a mom who's got, a month-old baby in her hands and she's gushing blood all over the place. And again, that's just not good care. She jumped into doing her life too soon. She isn't healing. You've got a placenta-sized wound inside of an organ. If you had that same wound on the outside of your body, everybody in the world would be like, why are you out of bed? Like, you're supposed to be resting. But women just kind of jump back into what they're doing. And especially if you're in a unsafe environment, a war-torn country where it's not safe for you to stay where you house, that makes sense, right? She's trying to protect her child. So you could have someone that's just experiencing a postpartum hemorrhage simply because there's other factors going on and it's weeks after she's had a baby. Now, in those cases, I would go to Methergin, but I highly doubt anyone in here is carrying that. So I would go straight to TXA because it's approved for up to 12 weeks postpartum. If you want to get really good data on that, the woman's trial, you can even just quote woman's trial in Google. It's going to bring up their website and TXA next to it. They have a beautiful website. While I believe that the study was done unethically because they practiced on women in China, India, and Afghanistan, because those countries you don't have to have consent from the patient to practice on. So while the study itself is unethical, the data that we got from it is very helpful. And we know that you can use, we have the data that proves to us TXA will save a mama's life up to 12 weeks postpartum.
Okay. All right. Very good. Like we mentioned in the very beginning, World Health Organization, number 2 cause parental mortality is infection. So, I mean, it makes sense. Like you mentioned, you have a great big wound. Like,
yes.
Again, like this is something that should be happening, all the time as far as like babies are being delivered. Like that's just a normal thing. Is it like the pregnancy? Is it the delivery that like suppresses the immune system, or is it people on the outside screwing things up?
It's a fact. Both would be contributing factors. So in order to stay pregnant, your immune system has to be systemically suppressed because we're keeping foreign bodies inside of our body. And so that's why you have women during their pregnancy, they're sick all the time. They got allergies, they had a cough, a sniffle, a sore throat, the flu, a GI. They always get a bug. Because their immune system is suppressed in order to keep an entirely different human body inside of their body. However, with that being said, we're built that way. We're supposed to do that. We're supposed to be shunting all of our energy to this other human body. So yes, that is a part of it. The other part is sticking fingers where the sun don't shine. So the biggest and the World Health Organization does talk about this. So if you dig deep and you look at their asterisks, they'll say repeated vaginal exams are the number one culprit. And that is the biggest reason for me personally as a midwife. I just don't do them that often. I mean, it doesn't matter how good I scrub my hands. It doesn't matter if I'm using betadine. It just increases the risk. Now, there's times for me to do that. If I have to suture her, right, that I'm going to have to touch things. Like that just makes sense. If I think that there's some sort of compound presentation and I'm moving a baby hand or I'm removing a cord around, then I'm going to have to touch things. So that makes sense. But in those situations, I'm cognizant of that. And then I'm having her rinse, and I'm having her wash, and I'm having her use her peri bottle to clean things and make sure that she's as clean as we can and minimize the risk. And I'm also looking for her at her vital signs constantly. I'm checking temperature repeatedly to make sure that I don't have those issues. And if I do, I treat them right away. So really just sticking fingers where they shouldn't be is our number one issue. But the other thing is, we've got folds. It's a big, wet, dark place, the uterus now, right? It doesn't have a baby in there anymore. It's all stretched out and we're working on healing. So increasing any sort of activity that shouldn't be done. For my personal patients in the States, 40 days in bed, it's not a negotiation. Like I'm not the midwife for you if you're not going to adhere to that. because it's so important. It truly is. I mean, anybody who has had any sort of surgical procedure knows that the way you treat yourself after that surgery is the way you will feel, good or bad, a year from then. And so we've had a major abdominal uterine event. we need to not be on our feet and not doing things. And I know that if we're in situations that are austere, that's not an option. And I get that. So being very on top of cleaning the area. And so I use a postpartum tea, which is going to have calendula and comfrey and sage and a bunch of things that are very antimicrobial. And they're also very healing. And so I just have her put it in her peri bottle, very diluted and cool, and rinse every time she goes, and no wiping, because that's going to irritate the external genitalia, which is going to cause those micro cuts and abrasions, and then things just grow there. And then staying on top of changing pads. That's another really big thing. So if you're going to change the baby's diaper, change your pad. Is kind of my rule of thumb, because it's wet, it's dark, it's moist, and it just it's supposed to trap things, right? It's supposed to trap blood, and that's just where stuff grows. And so just change it every hour and a half. You need to have a new pad on.
Well, that tea is not part of my tack set. So
no, it's not. I'll send you some. How about that?
Okay, perfect. Would just basic soap and water be okay?
Yeah, you could even do betadine, right? Or if you had some betadine, and that would be totally fine. I know you guys, we love things that do multi-duty, right? And so I would just super duper duper dilute it. Should be more of a pinky rather than an orangey color. And that would be great, because we don't want to cause stinging or anything like that. Witch hazel would also be good. I love having that in my kit because it's also very multi-purpose. But you could also do, have her rinse with the betadine dilution and then witch hazel on top. That would be great. I would just squirt her pad with witch hazel, and that way it's just sitting there and really kind of drying everything out tissue-wise, but keeping things really clean as best as possible. And then, just don't touch things that you shouldn't be doing, and you'll significantly reduce. And even when I was explaining the delivery of the placenta, not one time do I say stick your hands in there, right? And so you're just letting everything come to you rather than going fishing for things. You'll significantly reduce the risk of infection. However, if you're getting someone that's brought to you that is a, feces hit the oscillating device situation, which is what we're typically getting, right, when we're working out of our backpacks, then you could be dealing with an underlying infection, and the postpartum the body is saying, get it out. So it's increasing the blood volume because it's like, just get this infection out. So you could be dealing with a multifaceted problem. So try really hard not to get pigeonholed and only go, oh God, the bleeding. Oh God, the bleeding. If I'm dealing with a late hemorrhage, I would absolutely A, control the hemorrhage, but then B, go straight into why is this happening? So now I need to figure out what's her temp, what's her blood pressure, where's the problem? Because you can also have a toxemia issue up to 12 weeks postpartum. And so God forbid, but you could have a trifecta of things going on, right? And the hemorrhage at that point is just a symptom. It's just a sign of one or two other big problems. It's not the main issue. It's the body attempting to control the problem, right? If you have a high blood pressure, the body's going, well, let's get rid of some of this blood. That should then I can regulate myself. Now, you and I know that that's not logical, and let's not do that. But the body doesn't think that way, right? It's going, I have a blood pressure problem. My head is pounding. Let's fix this. That's the path of least resistance. You can also have an underlying infection because she was unable to keep herself clean. And now the body's going, get out. So let's increase the blood flow and let's just, solution to pollution is dilution. And let's just get rid of it. And again, none of those are logical and none of those are going to fix the problem, but the body's just, it doesn't think like that.
Just going to my like war wound therapy as far as antibiotics, would I be wrong doing that?
Oh, no, absolutely. Yeah. And you can absolutely go, okay, this is just again, feces hits the oscillating device situation. Let's just hit her with everything. Because I personally would do that too. And we're going to have different antibiotics based on who we're working for and what umbrella we have over us. But, as long as it's approved for the situation, I would absolutely use it. Some of those things are going to complicate. Some of our treatment plans are going to complicate breastfeeding, but I'll deal with that problem in a second. I need both of them alive, and then I'll fix the breastfeeding problem.
So like you mentioned, you've worked with medics, whether they're conventional or special operations. I'm not carrying OB stuff. I don't have a lithotomy chair. I don't have speculums. I don't have any of that stuff. What if I was going to have a kit, hopefully the kit that I would never, ever have to touch, what would you have in it?
Well, I made it. So it's called the Combat Midwife Emergency OB Kit. And it is the most whittled down version of the stuff that works. Why did I recreate the wheel? It's because the OB kits that are on the market have nothing but a bunch of junk in them. It's a bunch of Chuck's pads, that stupid apron thing. Like, am I eating mussels? I don't know what's going on here. Like, it's just, there's nothing in there that's useful. So I put a bunch of really great, so the postpartum herbs are in there. The appropriate suction device, which is a Deli suction. I don't like a bulb syringe. I mean, they're in my bag, but I don't use them. They're great for irrigating. They're really crappy for getting stuff out of babies' noses. I don't like them. I put all of the things that you would need to take care of both mom and baby during a labor and immediate postpartum, and it's all in that kit. So that's what I would do. And I made it compact because I know you guys are like, oh, I don't have any more room to stick junk in my bag. So while it does come in its own case that is waterproof, you could very easily take everything out of there and disperse it into your bag if you wanted to. The reason I came up with it is I was training a team that was going on a sort of humanitarian mission. I'll let you read between the lines on that. And they knew that there was a potential to be taking care of people in the populace, and they just started asking a bunch of questions. So we dumped out the, typical Army aid bag, and we went through it, and I was like, let me dump my bag, because I always have, of course, my stuff with me. And I said, here, you can have this, and you can have this, and you can have this. And so I said, you know what? I'm just going to make something that they can just get and either put on a piggy bank and add it to the outside of their aid bag that they can clip it on and off. That way it's not taking up space. Or you can just throw it in your car or whatever you're doing and leave it there. So, the only thing is it can handle temperatures. I would just not do extreme cold or heat, only because the herbs will either disintegrate or they'll freeze, and then they're not helpful for you. But you have to do that with your meds. I would just take those out and stick them with your meds that you're going to move in and out of your bag anyway. But other than that, everything you could piggyback it off of your own aid bag.
Sure. Okay. So obviously you have a website. Would you mind telling me a little bit about it?
Yeah. So I have, my website's combatmidwife.com, and I have a bunch of free material on that site too. So you can kind of pick my brain. But they're on the publications page, there's a whole bunch of podcasts that I've been on previously. So you can kind of binge listen to me if that's something you want to do. But I also have articles I've written, a EMS textbook I wrote the whole entire special population section for, so you can read all of that. And then all of that it's open source, so you can read the book on your tablet or computer or whatever. And then I have courses all across the country that you can sign up for. So I have an 8-hour, it's an all day, it's until you're done for the students, hands-on class where we go through everything from a normal delivery, everything's gone wrong, postpartum hemorrhage, cord around the neck, breech delivery. And we go into the first year postpartum. And so we're talking about mom and baby and the problems that can happen. So everything from breastfeeding problems, how to rehydrate an infant, fever in an infant, the weird rashes, what's scary, what's not, jaundice, all the stuff that would freak you out if you couldn't get to the hospital. And we talk about what we have in our aid bags and what we can do with the stuff that we actually do have.
Awesome. Well, thank you, Jessica. I really appreciate you jumping on.
Thank you very much for having me. I appreciate you.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.